evidence-based approach to systolic and diastolic heart failure. The way I'm going to go through this, we'll look at systolic heart failure first, sort of medical treatment, then device-based treatment, and then diastolic or preserved ejection fraction heart failure. This is a normal structure of the heart. Over here we have a dilated cardiomyopathy with changes in the structure, dilation of the left ventricle, the problems with mitral valve closure, et cetera, everything that we all know happens in heart failure. This is probably has been seen by you as well. The heart failure pathophysiology. We have left ventricular systolic dysfunction, decreases cardiac output, decreases systemic perfusion, and we see an increase in pulmonary pressure and pulmonary congestion, sort of classic of what we think of as heart failure. This leads to neurohormonal changes with an increase in sympathetic nervous activity, which increases our heart rate, contractility, and cardiac output, stimulates the renin-angiotensin system, and has all these deleterious effects of sodium and water retention, endothelial dysfunction, organ fibrosis, more left ventricular dilation, hypertrophy, oxidative stress, vascular remodeling, and immune system activation. So this is a pretty bad cycle to get into, and many of our patients, as you know, do. The epidemiology of heart failure, this is, seems like everything in cardiology we keep saying is going up and up and up, but it is because people are getting older and we're keeping them alive longer. And so all of the cardiovascular diseases you'll see more of. We had almost 5 million patients here, and then we're looking at 10 million when we go out to 2037, about 550,000 cases new each year. That's in addition to all the chronic heart failure patients you follow. And then we all know sudden death is higher in our heart failure population, 6 to 9 times higher. Looking at patients in the United States in the millions, in 1991, about 3.5, 2001, about 5 million, and then that's the projection, 10 million. It's a huge problem, public health problem. There are 900,000 annual hospital admissions. Most common discharge diagnosis for our older patients is heart failure. There are millions of hospital days per year. It's the single largest Medicare expense. And annual hospital and nursing home costs estimated to be in the billions. Whoops. Here, 15.4 billion. What are the problems that our patients experience? Congestive symptoms are maybe the most obvious, but they also have significant activity limitation, dysrhythmias. This is my area, as you know. Hospitalization, hospital costs are tremendous. I don't know if you all have noticed in this economy, but I've had more people ask me in the last year, what's the copay on that, than in my in the 20 years that I've been doing this. And I mean, have you all seen that too? I have people refusing treatments and alternatives because they say, I can't afford the copay. I've never seen that before. And heart failure leads to reduced survival. The risk factors for heart failure are well known. This is just a graph from the Framingham study looking at men and women and in population attributable risk. There are some differences. For example, in hypertension is more prevalent and a problem in women than men, but in general, hypertension, myocardial infarction, coronary disease, valvular heart disease, left ventricular hypertrophy, and diabetes sort of affect men and women as risk factors for heart failure. This graph just depicts the increasing rates of heart failure hospitalization among our elderly patients in the United States. In the blue, we have the younger group. These are the younger group, 45 to 65. This is getting younger every day for me. And but over 65, rates of admission tend to go up rapidly. This is the same sort of thing only in a graphic thing. Patients, this is patients who are readmitted for heart failure. Once they've gone home, we like to think we do a really nice job of taking care of these patients and making sure they don't come back. But the fact of the matter is that 2% come back within 2 days, so we do all right very short term. Within a month, 1/5 come back to the hospital, and within 6 months, fully half of our patients have been rehospitalized for heart failure. So clearly there's some room to improve there. Interestingly, this has been looked at. Many of the reasons that people are rehospitalized are preventable. So this diagram shows preventable causes of heart failure readmission. Greater than 50% of the time, the issue is medical noncompliance, diet noncompliance, inadequate discharge planning, inadequate follow-up, failed social support, or failure to seek medical attention. I mean, some of these are really problematic. For example, medical noncompliance. How many people in here take a medicine every day? All right, how many take it every day? Well, not everybody who raised their hand the first time, and I didn't raise my hand because I forget too. I mean, medical noncompliance is an issue. You give people a bag full of pills and expect them to take them every day religiously. It's hard for people. Diet noncompliance is another area that I sort of have a running argument with some other cardiologists in my group. I think putting people in the hospital and feeding them cardboard and expecting them to go home and do the same thing is silly. So I give them maybe not a regular diet, but I don't give them the completely low sodium, low cholesterol, eat wood chips diet, because it's not going to happen when they go home, and I'd rather adjust their medicines to what they're actually going to eat. I'd be happy to talk about that in the breakout, and I'm sure somebody wants to argue with me. My partners argue with me. Our goals of heart failure management, we really want to improve symptoms in the short term, and this is what our patients notice, that they feel better. But long term, we'd love to reverse cardiac remodeling, we'd love to improve survival, and we'd also like to do electrical remodeling. I like this diagram because it's a sort of a stepwise approach to heart failure, and it implies that as you go from this side to this, that the heart failure is progressing, and that your treatment strategy is progressing and getting more aggressive. So, for example, stage A heart failure is high-risk patient with no symptoms. So here you're just going to be looking at risk factor reduction, patient and family education. When you get into, for example, stage C heart failure, which is structural disease and symptoms, now you're looking at what we all know is good treatment for heart failure: ACE inhibitors, beta blockers in all patients, sodium restriction as you can, some other medicines, and then you go on to the more aggressive things, which this is my favorite part, the cardiac resynchronization, if bundle block is present, revascularization. And then stage D, refractory symptoms. Here you're really coming to the end of the stairway. Refractory symptoms, where this is the end stage heart failure patient, where they need inotropes, perhaps chronically, VADs, ventricular assist device, the surgeon's implant, transplantation perhaps, and something that we don't consider enough, in my opinion, and that is hospice for these end-stage patients. Okay, so ACE inhibitor and beta blockers, these are recommended for prevention of heart failure in our patients at high risk for this syndrome. Those would be patients with coronary disease, peripheral vascular disease, previous stroke, diabetes, etc. Strength of evidence on that is an A, which is unusual in a lot of our cardiovascular information. ACE inhibitors and beta blockers are recommended for all patients with prior MI. So, in general, patient has cardiac disease. If they can, they should be taking ACE inhibitors and beta blockers. Substitutes for ACEs. Many of our patients cannot tolerate an ACE because they develop the chronic cough. In that case, an ARB is recommended. The combination of hydralazine or a nitrate can be considered if they can't take either of those medicines. And patients intolerant to ACEs because of hyperkalemia or renal insufficiency, you could also consider the combination of hydralazine and an oral nitrate. Beta blockers post-MI, Capricorn is one of the studies that showed us, looked at the impact of beta blockers on post-MI patients with a low EF, so we're still talking about patients with systolic dysfunction. They were already receiving current treatments, revascularization, anticoagulants, aspirin, ACE, et cetera. All-cause mortality was reduced with beta blockers, cardiovascular mortality was reduced, and recurrent non-fatal MIs were reduced. So beta blockers are recommended. We've got lots and lots of evidence that beta blockers are good in this disease. This is just sort of a listing of these beta blocker trials, and this is what you should focus on, that there was a 48% decrease in disease progression here, 34% decrease in mortality. Here again, decrease in mortality, decrease in mortality, decrease in mortality. So whereas 20 years ago, we thought about whether to add beta blockers, or we were nervous about adding beta blockers, the standard now is to get people on beta blockers and have them on the highest dose that they can tolerate for this particular problem. We've also got good evidence on aldosterone antagonists in heart failure. The Rouse and the Ephesus trial compared spironolactone to placebo. On this axis is probability of survival, so that means that if the higher line is better, because more people were alive at the end of the day, and both of these, spironolactone performed better than placebo. One other note on just sort of a subgroup on the hydralazine and oral nitrate combination. This is recommended as part of standard therapy in addition to beta blockers and ACE inhibitors for African Americans with left ventricular systolic dysfunction. New York Heart Association class 3 or 4, strength of evidence is A. Even class 2 heart failure, strength of evidence is still pretty good, and so that should be added to the standard therapy. And then we all use diuretics as well to restore and maintain volume status in our patients. We use it for people with congestive symptoms, signs of elevated filling pressures. Again, strength of evidence is A, and we prefer the loop rather than the thiazide type diuretics to attain that volume status. So this is sort of a summary slide. We've talked about diuretics, ACEs, ARBs, beta blockers, aldosterone antagonists. These are all very standard treatment for patients with left ventricular systolic dysfunction. In certain groups, the nitrate hydralazine combination. Some patients did, particularly if they have atrial fibrillation. And then there's this, the piece in the middle here that's my favorite part, CRT, cardiac resynchronization therapy, plus or minus an ICD, and I'll just spend a couple minutes talking about my favorite part. This is resynchronization therapy, and for those of you who do not use this, it can be a miraculous addition to your heart failure patient's treatment. Basically what it is a pacing device approach to heart failure, so patient doesn't use any extra energy to get benefit from this treatment. So for example, inotropes that make things move more, inotropes use up heart energy. This does not. This uses a battery's energy. So it's a transvenous approach. We put a lead in the atrium here, a lead in the right ventricle, usually an ICD lead, but it doesn't have to be. It can be just a pacing lead. And then we thread a lead here into the coronary sinus, out to the lateral ventricular wall. And the reason we do this is if you can do it transvenously, it's really nice. It's a very established treatment. It does require access to the coronary sinus, so people who have this done should have it done somewhere where we do it, people do it every day. And what does BIV pacing do? Well, acutely it reduces mitral regurgitation, which is a really nice side effect. It can have acute increases in blood pressure, which in these patients is usually a good thing. Usually they're living on 80, 90 systolic. Over time, it decreases LV size, increases LV function, and improves LV synchrony. This has been looked at in many trials over a long period of time. The change in EF is control is in blue, resynchronization is in white, and so the EF goes up when compared to placebo, and the mitral regurgitation jet goes down compared to placebo. So this was a trial looking at it had nothing to do with a defibrillator. These were biventricular pacemakers, and even with just the pacemaker, no defibrillator added. This looks at the percentage of patients free of death from any cause or unplanned hospitalization, and the cardiac resynchronization group did considerably better than the medical therapy group. So that's remarkable that there was a decrease in sudden death even without defibrillator implantation. So who needs it? Anybody. We consider people who are on standard treatment with optimal medical therapy with a left ventricular dysfunction and a left bundle. What about the defibrillator part of it? Defibrillators are so ubiquitous now, they're getting into sort of our comic book stuff. Indications for ICD implantation, they are very well established. There's primary and secondary prevention, and it's very guideline driven. This is the number you need to remember. For an EF less than 35%, that person is an ICD candidate. There are a lot of caveats to that. I'll be happy to talk about it in the breakout about who should or shouldn't be referred for these devices, but this is the number to remember, less than 35%, whether it's long or short-term 35%, that person is possibly a candidate. We have lots of information that there's a reduction in mortality with ICDs. Again, I can go over that in the breakout, but we have thousands and thousands of patients that we've demonstrated a decrease in mortality. The only other device that I just mentioned is the LVAD. These are being used now for destination therapy, which means we used to only use VADs to bridge somebody to transplant. So if somebody was dying, we'd put a VAD in and then hope they got transplanted before the VAD got infected or thrombosed. We now they're small enough and good enough that we use them for destination therapy, meaning the patient goes home, lives the rest of their life with a VAD. And we've got many, many patients with destination VADs who are doing, going out dancing, doing regular stuff that they couldn't dream of doing before they had this device implanted. And then I told you end-of-life care should be considered in people who have, stage D heart failure, frequent hospitalizations, terrible quality of life, continuous IV support. I think we should consider hospice in this group sooner than we usually do. All right, switching gears, heart failure with preserved ejection fraction. So this is it used to be called diastolic dysfunction. People prefer this now so that you're making the distinction between preserved and a decreased systolic function. So preserved ejection fraction, don't use diastolic dysfunction anymore, although everybody still says diastolic dysfunction. But in the literature, you'll see this more now. Heart failure with preserved ejection fraction. Interestingly, LV function on 2D echo with heart failure in the elderly, fully 50% of the patients, even though they have heart failure, have a preserved ejection fraction. And if you look at the differences between men and women, women tend to be the larger group of patients who have active heart failure and a fairly normal EF. It's about 50% of the total heart failure population. There's particular prevalence in the elderly, females, and patients with hypertension. Average age is 73 to 79, so this is in our sort of older heart failure population. And again, majority or a large number of the patients are women. The effects of aging on our cardiovascular structure and function, aside from the AFib that 20% of our population will get, aging also affects just heart muscle and vascularity. We have increased vascular stiffness, increased myocardial stiffness, decreased beta-adrenergic response, impaired mitochondrial ATP production, and impaired endothelial function. The net effect of all that is a marked reduction in cardiovascular reserve. What is the pathophysiology of this? And I'll add here, this disease is, I think, far less well understood than people with systolic dysfunction. But these patients have hypertrophy, they have concentric remodeling, abnormal calcium handling, an abnormal relaxation and filling of the ventricle, and then decreased diastolic distensibility. So they've got stiff left ventricles, and they can be quite difficult to manage. This is looking at exercise capability in healthy subjects. As we're all probably annoyingly aware, as we get older, our exercise capability goes down, starts at the age of 20. So your peak was when you were in high school, just for that good information. Men start with a higher capability but decrease at the same rapidity as women. This looks at exercise tolerance in patients with preserved versus impaired, so diastolic versus LV dysfunction. In blue is normal, in this tan color, systolic dysfunction, and in the green is the diastolic dysfunction or preserved EF. There were 28 patients in the normal group, 63% women, 60 patients in the systolic dysfunction, 35% women, and in the diastolic dysfunction, 59 patients, 86% women. And what's interesting here is that this is the normal sort of peak exercise in the normal group, and it's hard to differentiate between the systolic and diastolic dysfunction groups in terms of exercise tolerance, which I think is a little bit surprising if you aren't familiar with this. This looks at functional status over time, again comparing patients with preserved versus depressed ejection fraction. Preserved is in blue and depressed is in green. And here again, over time, these patients improve, maintain, decline, or died, and there's not a huge difference in these. There's no significant difference between those with preserved or depressed ejection fraction in terms of how their functional status progresses over time. In terms of morbidity and mortality, there's no difference between the preserved EF patients and heart failure with reduced EF with regards to all-cause readmissions, heart failure readmission, or functional decline. There is a little bit of a difference. Patients less than 65, mortality is less than heart failure with a reduced EF. Patients greater than 65, mortality is similar between the two diseases. This looks at survival following hospitalization for heart failure in the US. Just the thing to note here, these are kind of funny lines. I didn't do this graph, but these are black and white, black and white, black and white. So there's no difference between those two groups. And just note that as patients get older, survival goes down after a heart failure hospitalization. This is a similar looking graph looking at preserved versus reduced EF in Olmsted County, Minnesota. And again, interestingly, survival is no difference between when the two diseases are compared. So what about treatment of this disease? This has been looked at in a fair number of studies. I'll just go through them briefly. There's the iPreserve study, irbesartan in patients with heart failure with preserved ejection fraction. I'm not sure that terminology is ever going to really catch on. It's hard to say. Heart failure, and there's no short way to say HFpEF. So maybe they'll come up with something a little bit easier. Anyway, this study looked at 4,000 patients with an EF greater than 45%, so that's considered preserved. Randomly assigned to irbesartan 300 a day or placebo. Follow-up was 50 months. Primary outcome, all-cause mortality or cardiovascular hospitalization. And this is what they found: no effect of irbesartan on mortality, readmission, or any other pre-specified endpoint. CHARM preserved looked sort of at the same group of patients, mean age 67, 40% female, EF here a little bit better, 54%, 56% were ischemic, and 29% diabetic. Patients were on, to start on, this was what they were on, 19% on ACE inhibitors, fair number on beta blockers, although not what we would like, 12% spironolactone, some on DIG, calcium antagonists. Follow-up was 3 years. And CHARM preserved reduced heart failure admissions, but no effect on mortality. A couple other studies have been looked at. PEP-CHF, it's perindopril, reduced heart failure admissions, and it improved functional status, no effect on mortality. Seniors looks at nebivolol, reduced cardiovascular admissions, no effect on mortality. The DIG ancillary trial had no effect on cardiovascular admissions or mortality. And TOPCAT, which is looking at aldosterone antagonists, is ongoing. This is a summary slide of heart failure, hospitalization, and controlled trials of renin-angiotensin inhibition in heart failure with preserved ejection fraction. So there's some benefit in terms of rehospitalization, but same look at all-cause mortality, and it's not, we haven't yet found the answer for that question. So for treatment of heart failure with a preserved ES, class 1 indication, control the blood pressure in accordance with guidelines. Remember, we think that hypertension contributes to this, the ventricle is stiff anyway, so controlling hypertension is very important. Control the heart rate in atrial fibrillation. Why is that important? Because it allows the ventricle more time to fill if you have a slower heart rate. And should give the patient an advantage. Diuretics to relieve congestion and edema. Revascularization, obviously, if you think they have coronary disease and active ischemia. So you look at anything that you can try to fix. Mode of death for these patients with preserved EF. This is looking at preserved EF. This is reduced EF, HFrEF. HFpEF. Non-cardiovascular death is more common with a preserved EF. Sudden death in the patients with LV dysfunction, and they die of heart failure more in the patients with LV dysfunction. So to wrap up, heart failure with a preserved EF is at least as prevalent as heart failure with reduced EF. The prospective treatment trials have been disappointing in the preserved EF group. I think we are pretty aggressive and do pretty well with the patients with left ventricular dysfunction. And given that most deaths in the preserved EF group are non-cardiovascular, treatment of comorbidities such as hypertension is critical. Both systolic and diastolic dysfunction or preserved EF dysfunction are common problems. They're going to increase as our patients get older, and the treatment options vary, and they're going to continue to grow and change as they have over the past 10 years, but currently include medicines, lifestyle, and as I said, my favorite, the device options.